All right, great. So, good afternoon, one and all. Nice to have all of you with me. Dwani ma'am, nice to have you. I've heard of the work which you have done with Pallium and a lot of work on end of life care in India, which has happened. Thank you so much for your contributions. Pleasure to have you here. So I think we'll move on to the topic straight away. Let's dive into it. Um, in common terms, we know that pain is usually something we attribute to as a very physical thing. But is there more to it? Is there other dimensions of a human being which is affected? When we use the term pain, is something which we are going to look at today. So I want everyone to be active. We are a small group right now. And please feel free to use the chat box. I don't want this to be a monologue. Also, feel free to unmute yourself if you feel so. So I want you all to look at the picture which is visible on the screen right now. And tell me what is the first few words which comes to your mind. What impressions is this picture creating on you? Emotional pain, distress, okay, turbulence, too many thoughts, confusion. Can we have some? The image over here that thunderstorm.
Sir, your voice is breaking. Sir,
As long as you can hear me, if there is any disturbance, please let me know. So yes, so all of you are very actively telling me about the image and describing about it. Okay, so this is like you all were describing. There is a lot of turbulence. It looks like there is a lot of pain. A lot of things happening inside that mind which you are seeing. So there is a thunderstorm which is there. Apart from the thunderstorm, there is fire, there is rain. At the same time, despite of all this, you can look at the soil. It is very dry and parched. Okay, this is what is happening inside a person, and the only indication of this turmoil which is going on inside is that teardrop which you can see on the outside. So this, in short, is the impact which pain can have on a person. And the only thing which may be visible outside is not much. So with that, we'll move ahead for today's topic, which is pain and its impact. So what does health mean to you? Yes, can we have some responses on the chat box? What does health mean to you? There are 24 participants. We can at least have a couple of responses. All of us would have heard the official definitions of health, which is famous, put out by WHO. So yes, there is physical, it's not just physical well-being, but there is physical, mental, social well-being as well. Now we are also looking at spiritual well-being. We are also looking at economic well-being. So a lot of elements are there. But one thing we can be sure of is that it is not just physical well-being, right? So it is a state of complete physical, mental, and social well-being. And it's not just an absence of a disease. With that, let's look at the story, a real life story which has happened in the past in Pallium, India. This is a real picture which was taken usually we censor pictures, but this person was in so much pain. He always had a hand on his head. It's like a naturally censored picture. He was diagnosed to have a type of head and neck cancer. Okay, a type of cancer of the head and neck region. For people from the medical background, you may be aware that any head and neck cancer tends to be very, very painful because there is a lot of nerve innervation in the head and neck region. So, any damage happening to the head and neck region is extremely severely painful. So, we have this person who was diagnosed with cancer of the head and neck region. He was on a lot of chemotherapy, radiation therapy from the Regional Cancer Center, RCC, which is always overburdened for the population which we have. He has a wife and 3 children and his elderly mother living with him. He came to us in a stage where the curative therapy or the curative intent of the therapy was over. This person was in so much pain that he has not slept over past many few months. That is the state in which we are seeing him. And we realize that there is so much going on in this person's life. So we started looking at all the dimensions, which is the physical pain which he is in, the psychological distress which he has got, the socio-economic concerns which he has got. He is not from a well-to-do background. He is from a below poverty line, socio-economic, strata. And of course, there is a spiritual dimension to every person. So when we look at all of this, is what we call it as total pain. So we are not just looking at physical pain, but we are looking at the total pain of the person. That is, it is not just at one dimension, but a multi-dimensional aspect, which every human being has. Even if we have a life-limiting illness like cancer or not, any disease which is incurable, which is lifelong, there are a lot of uncertainties which is there. And the physical part of it is just one element. So I often say that once we look at the person, give some investigation or a prescription, what happens outside the 4 walls of the OPD, that is where that person's life starts. Because we are looking only at few things when that person is sitting in front of us for a consultation, maybe for a few minutes. So illness-related suffering is definitely much, much more than just physical distress. Would you agree? Right? So there is so much more happening. And if you really want to address the health of a person, then we have to start looking much beyond that physical distress alone. And only when we start addressing the other concerns, the other uncertainties, and try making solutions for those aspects, are we going to truly address health. Because pain has got an impact on all the dimensions of the person as well as the family members. And we, as being in the health care sector, with the word care in commas, is something which we need to bring back. That is the care. Now it has become a health industry, but we need to bring it back to a health care industry. So let's move ahead. Can you all come on the chat box and tell me? I've given you a brief background of this person. What all are the things which will be going on inside this person's mind right now? Can you come on the chat box? If somebody wants to unmute, please feel free to do so. Okay, Fabi, given up. Anything else? Finance,
family, what will happen in case of his death? Okay, there is anger and frustration. Am I becoming a burden for people around me? Yes, very important question, very practical. There are so many liabilities. Yes, am I becoming a burden? There is a lot of hopelessness. I wish to die. Okay. Somehow, someone, please help me to sleep. Yes. Is worth living such a life? Is it worth living such a life? So, as you all are telling, why me? Yes, suicidal intentions. Why me? Why is this happening to me? That is a question we ask in the spiritual dimension. Day to day needs are not met with. So, there is despair in life. Very correct. All of you are correct. I have just put a few thoughts over here. Will I be able to pay my medical bills? It's a myth that everything in a government hospital is free. It is not so. There are expenses over there as well. Am I going to be able to pay my medical bills? How will I provide for my family? He was the only earning member doing some menial work. Yes, Dr. Payal Advani, there may be repentance due to habits and illnesses. That is one of the reasons why we don't delve into asking pointless questions like, were you using tobacco in the past? Were you habituated to using alcohol? We are not concerned about those things at all. So this adds to the guilt of the person. And it's not going to make any difference in the disease trajectory or treatment protocol anyways at this point of time, usually. So we don't explore those things. So yes, how will I provide for my family? I don't want to talk or eat. There's just so much irritation. There's just so much going on. I don't want to talk or eat. There is just too much pain. I'm unable to sleep for so long. Can somebody help me out with this? Am I going to die now? These are all the questions which naturally comes to a person who is who is going through such an illness. Is there any thoughts which somebody wants to share?
It's just overwhelming to have so many thoughts.
Yes, absolutely yes. It's too overwhelming. It drains out a person completely. Just the sheer amount of energy which goes into thinking about all these things, which we have usually people take for granted. When we know that there is limited time. We know that there are so many responsibilities which we had. Definitely overwhelming, definitely energy consuming. And this happens every waking moment for the person's life. Especially because, see, in this person's case, he has been going in and out of a doctor's room for quite long. Not even a single doctor was able to provide him sufficient pain relief. We'll look at how we address this person in a while. Moving ahead, pain and depression. Tell me one thing. Just imagine yourself. You have come back after a long day's work at home and you had a tiring day. Of course, in a workspace, usually things don't go your way. There's a lot of give and take happening. And you didn't have a good day. Because of this, you have a headache and you come home. Now, when you come home, you're expecting your partner or whoever your family member at home to give you a hot cup of tea. But they are having their own bad day of their own kind. So they start taking it out on you. Maybe they are not cooperating with you, or they need somebody to share their frustrations with, and they start giving it to you. Is your headache going to increase or decrease? Yes, on the chat box. definitely increase, right? All of us have experienced this. I just used headache as one example. Whatever is it that you're going through, that negative emotion on that particular day, it is going to compound, right? Now imagine this happening on a number of days. Because I'll tell you what happens with a life limiting illness. The symptoms keep increasing day by day. Every single day, the symptoms keep increasing. Your uncertainty keeps increasing day by day. Your family members, after a point of time, they would like to be there for you, but they don't know what to do. Many a times we have heard the spouse tries giving them their favorite food, but the person is just not in the mind or the physical condition to enjoy that food. There is loss of appetite, which happens. And in that state, he will say, "What are you doing?" He takes out his anger or frustration on that person who is trying to help the person. So the family members start getting confused. Like Dr. Advani said, yes, they start getting fed up. The family members also, after a point, starts getting fed up. Something which we call as caregiver fatigue. So after some time, like somebody had mentioned earlier, they start feeling that, am I a burden to my family? That question starts coming up. And along with all that, clinical depression also starts happening, where you need to support that person psychologically, not just through counseling, but sometimes even through medications. So it is a known fact that pain and depression coexist. It can co-exacerbate. If you don't take care of one, the other also increases. It is interlinked. The human being is an organism where all these things are interlinked. There is a lot of talk about work-life balance going on. But we have to understand that work and life both is interlinked. They co-exacerbate. They coexist. Look at this statistic. Less than 4% of people in India have access to pain relief. So consider the whole scenario. It looks quite grim, right? So many a times, or almost always, we need an interdisciplinary approach for pain management. Because, like we had mentioned, pain is not just physical. It is multidimensional. And many a times, it is not the job of the primary treating physician alone. That primary treating physician, irrespective, he may be a palliative care physician. Still, it may not be his job alone. He may have to take the support from other specialties as well. So pain and depression, yes, they can coexist. There are enough and more studies, if you Google it, which will give you a lot of statistics about how there is a lot of distress. There is emotional, psychological distress amongst people with life-limiting illnesses. There is a lot of mental health issues, different kinds of diagnosis, which you can look at over here. So many different kinds of ailments. We have given a lot of names to it. But in a very basic sense, the mental landscape gets severely affected because of the illness in the physical body. And once these two are debilitated, that is, the physical and mental faculties of a person is debilitated, how are they going to pay attention to their social circumstance, to their social surroundings, to the economic needs of the family? Mind you, India is still a place where majority of our population is below poverty line. Majority of our population lives in rural areas. Many a times on the television screens, whatever news comes out are happenings from metropolitan cities or big cities. But 65% of our population lies in the rural landscape where forget about access to pain relief, even access to good quality health infrastructure is seldom found. So there are so many elements which needs to be addressed. So what is the impact? This is just about cancer patients, but even people with non-cancer illnesses, even people with diseases which we know a lot about, for example, diabetes. Don't people struggle with controlling diabetes? Just the discipline of having to take the medicines, wanting to indulge in the simple pleasures of taste, leading to complications of the eyes, of the kidney, of the nerves, leading to issues which may even need amputation of certain body parts. So even for non-cancer illnesses, as simple as diabetes, it is just a matter of time. And that is why now we are saying that palliative care has to be integrated into all healthcare. And it has to start at the time of diagnosis, not when nothing else can be done or when the person is near end of life. So yes, there have been statistics which have been said that psychiatric disorders affect at least 30 to 35% of cancer patients. I won't be surprised if it is more. A percentage of cancer patients face a lot of demoralization, anxiety, loss of meaning, existential crisis, and higher the depression, poorer the treatment outcomes. This is true with even controlling physical symptoms, because there is a strong psychosomatic aspect of disease as well. A lot of things is there in the mind. It starts manifesting on the body. So the impact of pain is so much more than what we are able to address or what a doctor usually addresses inside an operation theater or an outpatient department. Now, the reason why I was telling is that majority of our population is below poverty line. 2018, there was a study which came out in the British Medical Journal, which said that in that particular year, preceding year, in one single year, 55 crore Indians were pushed below poverty line. 55 million Indians were pushed below poverty line. So this is what we call as catastrophic health expenditure, when the socio-economic class of a person or a family comes down by one level or multiple levels. That means a middle class family comes into the lower class category economically just because of health related expenditure. I don't know how many of you know, I was told that there are social workers also in this group. The penetration of health insurance in our society is very poor. Yes, there is Ayushman Bharat, but I want you to know Ayushman Bharat is not an insurance scheme. It is an assurance scheme. It is assured that you will get people who are below who are below poverty line will get a coverage of up to 5 lakhs. But there are a lot of loopholes and the system needs strengthening. It will take time. It is not 100% yet. So when there is high financial burden, there is poor health related quality of life. It is very simple that whenever we need healthcare, we would like to take private healthcare than government healthcare. There are enough number of statistics available which shows that majority, depending on the area, anywhere between 60 to 90% of a population in rural and urban areas want to depend on private healthcare than government healthcare. So obviously they will pay out of their pockets, especially in the scenario of not having a health insurance. Now, when we are talking about that 65% of population which is below poverty line, for them there is high financial burden, which leads to lower health related quality of life because their affordability and accessibility is poor. As we have been mentioning till now, it leads to poor mental health. And this also leads to non-specific psychological distress. The person is just not okay. They are not able to pinpoint what all are the issues because there are so many issues which is there. So they go into non-specific psychological distress. And when you start conversing with people, you would see that many a times it is not death or pain that is to be feared, but the fear of pain or death. Because just the uncertainty of pain or death, that uncertainty is the difficult part. And that is where we as palliative care physicians, especially for people who are moving towards end of life, that is where we have to walk with them in that tunnel of darkness to move away, to put aside that fear, that uncertainty which is there. And this uncertainty happens not only in the end of life, but any life limiting illness or any incurable illness. It starts from there. Doctor, what is going to happen to me? This disease is going to be okay, right? I'll be able to manage, right? Many a times, the people go into a shock on hearing some diagnosis that this is going to be lifelong. They'll have to take some medicines, which is going to have some side effects for the rest of their lives. So, it is that fear of pain or death which needs to be addressed. Incidence of suicides in patients with life-limiting illness. Would you be surprised? Of course, when there is so much of health-related suffering, or as we say it in the palliative care world, serious health-related suffering. That is health issues which can compromise the quantity and quality of life in a crippling way. And this rate is highest incidence of suicide in people. This study is for cancer. In the first 6 months is the highest because it is during that time that the uncertainty is maximum. There have been any number of times when a patient has told me or a family member has told me that the doctor just read out the pathology report in front of them with the words cancer in it and then told what next to do. There is no more explanation given. It's as if we expect the person to understand. Yes, Dr. Payal, insensitive behavior. I am on that side of the doctors, but unfortunate to say that still many of my colleagues out there, that insensitive behavior is there. And that is why we look at something called as insight. What is the insight of the person? How much does he know about the illness? What are his thoughts about what symptoms he is going through? Etc. So many elements are there. So coming back to Mr. A's case, his wife also had depression. As somebody was mentioning, she had got fed up. She didn't know what else to do. She had reached the end of all the solutions which she could have given at home. Yes, life totally changes. So up to 40% of caregivers show clinical depression. Again, not surprising. And of course, higher this distress, there is increase in morbidity and mortality of the person as well. So let us look at how is it that we made the total pain of Mr. A into total care by addressing the different dimensions in this person. Very common, I mean, all of us in the palliative care world at least know this. There is something called as an opioid trial. Yes, you see many a times the doctors, when we have, since childhood, we have been going to doctors, right? And they will, whenever they prescribe pain medication, what is it that they say? Can somebody either unmute yourself or write on the chat box? When they write pain medications, what do they say usually? Well, there are doctors in this group. Okay, yeah, SOS. Only if it's unbearable, have it. Don't take it for too many days. This is not good for you. Somewhere we are also responsible for the impression. Yes, don't take on a daily basis. Take pain only when there is pain. Exactly. That is what the doctors have been telling this person also. I agree that if a person is having a minor injury which may get sorted by itself after 2 or 3 days, these advice is warranted. That is, it's okay to say these things. But somewhere we have kept common sense aside. Even for a person who is having unbearable pain, which has taken away his sleep for months together, this is the same advice which we are giving. Yes, things are changing, but a very slow pace. We are having the world's largest population. There's a lot of misinformation out there, and there are a lot of doctors who need to learn the art of pain management. So, yes, for him, it just took us 10 to 20 minutes to give him opioid trial, where 1.5 milligram of morphine was given to him intravenously, repeated every 10 minutes. In 2 or 3 doses, he started feeling much better, to a point where he had 100% pain relief. He went in awe just to see that this was possible, that this is also a doctor, and he has been meeting doctors for last couple of years, and nobody offered this to him. So, physical dimension taken care of. There was a psychiatric consultation which was facilitated for both the husband and the wife. Some counseling was done, medications were prescribed as per the psychiatrist. There is a saying which goes, the power of a community to provide health is much greater than any clinic or hospital. It was told by an American physician. I forget his name right now, not able to recollect, but very true. When the community starts getting involved in healthcare, the extent to which solutions can be made for problems in the different dimensions. See, after all, we have to agree that there are certain limitations. Just as in training, usually a doctor and nurse, which comprises of the main team, they are trained to address only 25 to 50%, right? There are 4 dimensions if we keep it simple. They are trained to address physical dimension, at the max psychological dimension. But what about the social sphere of the person's life? The life of the person outside that hospital. That is where his identity lies, his community, his work, his family, his friends. All those things get impacted. So, when we start engaging the larger community, by this, I am bringing in community-based palliative care. That is, whatever we can address through medicines or inside a hospital, we do it there. But for the socio-economic and for the spiritual dimensions, his larger community has to start getting involved. In Pallium India, we are lucky to have a strong group of volunteers who support at multiple levels in psychosocial support, socio-economic well-being, and addressing spiritual distress for our beneficiaries. So here we ensured that the social worker, we have a strong group of social workers, 15 strong. They ensured that there was volunteers who came into the picture. They found sponsoring for the education of the children. And for the wife, a poultry business was set up at home. Yeah, it's not glamorous, but she was unskilled. And at least she doesn't have to put her hand out in front of somebody for money or for food. That is, living with dignity was facilitated. And that addressed the spiritual dimension of the person as well, of the family. That is, when you're always receiving, that is one way of life. But when you start contributing back something to society, no matter how small it is, there is a dignity in living. So whenever I see people selling something on the street side to live, I always wonder that isn't it great that they are making that attempt to live in a dignified manner? Even small things, maybe selling a pen, maybe an umbrella, some cloth items, something. So this addresses the spiritual distress or dimension of a person. And this is how Mr. A's total pain was addressed with total care. So yes, to conclude, there is a high prevalence of mental health issues, not just in cancer patients, but also in patients having non-cancer, incurable, lifelong illnesses. Always there has to be a multidisciplinary approach. And this is not just for other specialist doctors. Over here, we are talking about also involving the larger community with volunteer involvement. And there has to be that approach of total care. And even if we are not able to do everything about everything, even if we start exploring what are the issues which a person is having, just giving them the opportunity to share, to vent out, that is going to reduce a lot of distress for the person. And it will also be a reminder for all of us in the healthcare world that health has to be addressed holistically. And to do that, we need the larger community. There has to be collaboration, a lot of collaboration between hospitals and NGOs, between the public health sector and the private health sector. For everybody, there is something to contribute. And only if we do that, will we be able to address the impact of pain on a person and the family. Here is just a picture of a community-based healthcare service. In the center is the father of palliative care in India. Ahead is our nurses, and behind there are some volunteers who are guiding them towards the home of a person. Certainly, you can look at the terrain. Many a times when we go to the homes of people affected by stroke, they can't step out of their homes because the terrain outside itself is not supportive. Especially if you look at rural areas where it doesn't have enough public health not health, but even civic infrastructure, the quality of life gets impaired severely. Yes, any queries? I'll be all ears for some time. Any queries or comments, thoughts which anybody wants to share? We have time.
Thank you for such a wonderful session. So,
Thank you.
Mike, it's I will not say it's a request. I'm just curious. Participants, anybody can just give me an insight. We understand the financial toxicity or the catastrophe it causes on parents, even in a middle class family, which is pushed into such a debt-ridden circumstances. But even though we have more funds, when people who help give by means of financial support, but even then, I feel that is one of the main areas, along with the other things, is very under estimated sometimes, because the patients which I have encountered in the corporate hospitals will be coming again and again there. It might be like midway between a very elite hospital and the GH because of the crowd or absence of facility in the government hospital. Somehow they come there. But when we speak to them, even though, like exactly you said, they would have used up the minimal insurance which the Prime Minister scheme or the Chief Minister scheme, as in Tamil Nadu, offers. What about the caregiver would have left the job or resigned the job? So now the breadwinner will be as a patient. Then this person, if the son is ill, the father leaves the job, or a brother or a wife or a husband leaves the job and sits with them, especially towards the terminal care. And I feel that is because even after the curative option is over, they were never told that the options, they have exhausted the options. So that is really painful to see. And in our own fraternity, we couldn't even talk about it. Even today morning, I was talking to Radha ma'am. She said, like, I lost the battle with my own fraternity. They repeatedly say we don't need palliative care. We don't need palliative care. All they need is home nursing care. Home services is enough. So it is like a very big question, and it sometimes it gives a frustration when we enter the field with no hope where to go, whom to approach, how to start, or a service. All we face is this kind of question. So I think I understand the psychological distress and other things and all those things. At least that I feel somehow they find some help in their friends, or not professional help, but this financial toxicity is literally killing the person as well as the family.
Yeah, ma'am, may I know what your background is?
I'm by profession, I'm an MDS doctor. I have come to Pallium, India. We were busy that day, and I met with Sunita or somebody else in the community program team. And I have done my FCPM, and hoping to establish palliative care service, an integrated one in Madurai.
All right, right. So, ma'am, I completely agree with you. Financial toxicity, as we call it, is a major issue. Of course, there aren't enough studies in India. Some of the people whom I know in the public health sector, they are in process of studying this. But even without the studies, we can say that there is just with the, if we just see in government hospitals, or many a times, if you look at the profile of people who require palliative care, you would see that financial toxicity is there in many of the families, very prevalent and very difficult to address because resource is limited. And this is exactly why I said that quote by that American physician who said that the strength of the community to create health is much more than any hospital or clinic. And this is where we need to move forward in a collaborative manner. One of the, you said you have been to Pallium. One of the focus areas of this year is collaborations, that we are looking at who are the different organizations, which are the different organizations, and who are the different people who are contributing towards health. They may not be contributing in the physical dimension. They may be contributing in the social dimension. They may be contributing in some other manner. We don't know. But this is an exploration which we all need to do. In our own locality, you are from Madurai. I'm sure Madurai is a big area. But when you start reaching out to people, I think there are going to be sessions on community engagement as well, if I'm not wrong. When that session happens, there are so many strategies which we can use. Just talking to our own community of doctors, or your own batchmates, or the local association of the dental people or the physician people, whoever it is over there, is one of the starting points. The residents association where you live in, bringing out this topic and having an introduction or a sensitization to palliative care, that is another starting point. Getting religious groups involved. Of course, there is vested interest in every group. Forget about religious groups alone. Every group, there is some vested interest. Let's not look at the negative side of it for the sake of this discussion. But every group has something to contribute. There have been times when I have had conversations with church congregations, and they said, they would like to look at the people who are members of their church. I said, perfect. That is what you should do. I don't want you to look at everything and everyone right now. You start small and then you look at growing big. So you want to start with people in your congregation? Perfect. I'll tell you what to do. I'll tell you how to identify those people who require palliative care. I'll tell you what we can support you as an organization. I'll tell you other organizations who can support you. Yes, if you have contributions coming in towards doing deeds, which is good, you can involve that in palliative care also to address the social dimension of palliative care requirements. And one very important role of palliative care, of course, there is a lot of training which needs to happen, is when to avoid unnecessary treatment. That is one area, like you were saying. It seems like the options which doctors have never gets exhausted. It is true. It is very true. And I don't know if we should blame it that way, because I have seen people who want to somehow hold on to that last rung of hope which they have. And for them, I say, okay, I'll be there to manage your pain for you. But if you want to explore other things, please do, if you have the means to it. But if you don't have the means to it, don't think that just because if you would have had a lot of money, things could have been sorted out for you. It is not so. Even somebody who's a millionaire or somebody who's below poverty line, beyond a point in certain illnesses, without an iota of doubt, you can say that this is it. There is nothing else to do other than trying to make your life as comfortable as possible. So it's a long process. And the whole effort of education and training in palliative care is to address the concern which you brought out, which is happening slowly. At least people have started thinking, the medical fraternity have started thinking, do we need to do this? There is a lot of evil also in that world, but let's keep that aside for now, because that needs probably a lot of law and order to come in place also. But yes, there are so many things to do. And the whole effort of this education and training sessions, awareness sessions, public campaigns, etc., is all this to create that goodwill, so that people know about this.
Thank you.
Anybody else?
Good evening, Doctor. I just wanted to thank you for the lecture, and I had a question regarding pain score as a tool. What has been your experience when it comes to the acceptance of pain score and understanding of pain score, especially with the Indian cohort of community, the Indian community that you've been working with? And secondly, when it comes to the socio-cultural, I'm specifically mentioning socio-cultural aspect because the way we look at pain in our country, this is general opinion, is we generally not even respect endurance and tolerance in our community, but also even celebrate endurance and tolerance, especially when it comes to gender. Like, when women are told to tolerate, you can't tolerate pain, you can tolerate, this is nothing, like, learn to tolerate it, not talk about pain. So how has this thing been for you with your experience? Because the focus here is pain and total pain. And still, I think when it comes to the Indian milieu, I think it would be a challenge. It must be challenging, I guess. I'm wondering. This is something that crossed my mind. Thanks.
Thank you for the question. So there are a lot of elements in this. A very interesting question also. I had just a couple of weeks ago, I had just gone on a drive. I'm in Tamil Nadu right now. I had just gone on a drive and there was a temple procession happening. Okay. And I'm not sure if Arya, can you just give me permission to share screen for this, for the other one, like for the other phone I am logged in from? I'll just try showing it to you.
Okay, sir.
If I can. Okay, thank you. So we have time, so I think that we'll just explore and just show this to you. Okay, it's still showing that only host can share in this meeting. I think my two of my names will be there. If you could just give me permission.
It's done, sir.
Okay, just a second. Parag, can you just tell me about your background?
Yeah, I come from a counseling background, counseling psychology.
Where are you?
Mumbai.
Okay.
Is that what you asked? I'm sorry, I missed the last one.
Yeah. That's all. I just wanted to know your background and where you are located. That's all. Just a second. Just give me a minute. Oh, I'm able to share only photos. It's a video I wanted to show. Okay, so I'll just describe it to you then. So basically, it was a temple procession. Okay, and in this procession, I was seeing there was a lot of commotion on the road, and I'm seeing this crane. The big crane on the road, and the front end of it, which has got hooks on it. The front end of it has got hooks, the big hooks on it to lift something very heavy. I'm seeing that on those hooks, there are people hanging with pins on their backs. Okay. And it was a huge celebration. And there were multiple cranes like that and a lot of youngsters. They are celebrating this whole event with crackers and drums, and the ladies are dancing and everything. So that is the picture which came to mind when you told this, the socio-cultural aspects of pain. And what is it that is actually painful? Were those guys in pain? It didn't look like. They were hanging in mid-air with the with this thing, and they even had pins going from through their tongue and through their cheeks. So I was like amused that okay, this is also another way of handling pain. It's not just the adrenaline rush, because probably they're up there for a few hours at least. Having said that, at least for those people, and I have seen certain spiritual traditions also, where for certain spiritual reasons, they don't want to take pain medications. It seems that there is it helps their being or their soul to progress towards the next destination better. And in those circumstances, we have to respect those traditions. Because like you said, India is so diverse. It's so diverse. They say that every 50 to 100 kilometers you travel, you will find a different subculture in the same area itself. So when that is the situation, who are we? What is our role? So we should not do anything unsolicited. When it is asked for, when you see there is a need, definitely we need to step in. But there are situations, even recently, as recent as last week, there was somebody I was seeing, consulting, and they didn't want the pain medications. Then I warned them, you will lose your sleep. This is what is going to happen over a period of days. It was pretty intimidating stuff because they wanted to hear what are the negative things which is going to happen. Person has got a GI malignancy, which is spread everywhere, peritoneum and omentum, everywhere in the abdomen. But the take on life is very different. And I had nothing to say actually. There was nothing I could do to convince him. So I respected him. I told that, see, I'll be there. If you need me, I'll be around. These are the ways in which I can contribute. But if you think your belief system is strong enough to pull you through this, that's your choice. But at least that's an autonomous choice which that person is making. It is not about those, that remaining huge set of people, like less than 4% have access to pain relief. So the remaining people who require pain medication access, they don't have. It's not like that. This is just a fringe group of people probably. But majority of people are not like that. They need that support. So definitely the need is going to be there, and we have to start addressing it also through capacity building. Now about pain score, see, I would say is that even if pain score is not accepted, pain score is something we just need some measurement. At least from 0 to 10, you tell me how much it pains for you. It doesn't mean that it is some standard scoring, actually. Because again, the person whom I was speaking to last week, that person told me the pain is 4 only. Okay, the pain is 4. So I'm thinking, okay, 4 is manageable. 4 should be okay. And then when I started exploring, I asked him, is it bearable for you? He said it's unbearable. So then I'm like, oh, so for him, his threshold, 4 score is unbearable. He is a person on the spiritual path. He is able to take it. Maybe he has some different threshold for himself. So now the next time onwards, when I started talking to him, I said, in terms of the outside normal people, what is your pain score? Then he started saying 8 or 9. So this is all about, pain score is just, it's a subjective scoring. You can even ask him that, is it so severe that you're not able to sleep? Or is it only trivial that you're able to do your day-to-day activities? No need to, of course, if you want to quantify, you can tell them. But many times people don't understand 0 to 10 also. There are times when we have to use other terms, other ways of gauging pain. So you can keep it as simple as you can. Not necessary to stick to it. But of course, if you are in a setting where everybody uses its standardized form as being utilized, then sure, numerical rating score is good. Is there something on the chat box?
So there is a question from Sakshi Jadhav.
How do you look at the gender differences and societal expectations, especially when women don't express pain? See, there is a lot of social evil and there is a lot of ground for us to cover. At least now, I am very happy with all these movements which is happening. If you look at my Instagram posts, I don't think so in this circle. But then people who look at my Instagram posts can know that I am pretty vocal about these things. And suppression of women is something which has happened very systematically in India. It's not over past 60 or 70 years. It is something which has happened over generations, over a few centuries. That is where this comes from. It has to be stamped out in no uncertain terms. And education, everything, awareness movements, all this is going towards that direction. We have a lot of area to cover. Especially this is where I see that, rural areas, all this news which is coming out is usually from cities, metropolitan cities, or areas like that, But we have a huge population who is there in rural areas where there is still that kangaroo court, we call it. I think there is somebody in the village who will decide how things needs to happen. Recently, I'd been to Haryana for seeing a patient doing some part of some palliative care audit work. And in that particular village, there is still all the important decisions of the village is being made by that, that group of men over there. So there is a lot of room, lot of area to cover in this as far as women are concerned. But certainly palliative care right now, with the way it is going ahead, we can be those flag bearers where we don't have to really be on a protest, but through our actions and our words. If there is a caregiver who is sitting, if there is a patient who is sitting, who is a female, we may want to talk to them separately and ask them what is happening. If she is uncomfortable to open up to me, I may ask my trained nurse, let's see, I think there is something which she is not expressing. When we admit her, or my social worker who is a female, can you go to her home, make a visit? There has been cases like that even in Pallium, the area where I used to be in charge of in Trivandrum. There is a family, both the husband and wife, second married. The wife had an amputation in childhood. The husband is having heart disease. They have a daughter from one of the previous marriage. The daughter is in 8th standard, 7th or 8th standard. And this husband will always come to us and he will tell he's not feeling well, he's in tears, and we always had a lot of soft corner for the husband. Once when we went for home care to his home, he had gone to his relative's house and his wife opened up. She said that he physically abuses her and the daughter. If not physically, he verbally abuses her. She's got a little deafness also since her childhood. So multiple issues were there with her. But then these are real cases which was there. And we were like aghast to hear this because the way he had created an impression on us, always crying, always he's very, whatever we tell him, he's willing to accept and things like that. But then later on, we heard a lot of things about him, how he's creating unrest within the family, how he has suppressed the wife and the daughter, and he has spread falsehood about her in the community. So then we started dealing with them differently. We even had our social worker go to the daughter's school to talk to the daughter during their lunch break, and so that we can get more information as to what exactly is happening at home. And right now, looking at the overall scenario, we have decided not to take a legal stand, but if needed, we have advocates who are volunteers who will support us. But the wife is not willing to go to that extent yet. For her, she just wants a peaceful coexistence with her husband and the daughter, because the daughter is also growing up. So as long as, since that day, few interventions we had done, he has at least stopped physically abusing them or hurting them. It's been nearly a year now. So we are on the lookout. If anything goes out of hand, we will escalate it. But otherwise, everybody is on board. So it was a multidisciplinary approach with the local volunteers, by talking to the woman's mother, and then our team also taking a decision on how to proceed. So yes, we can be flag bearers for women's causes also through palliative care. And there is a lot of things which goes unaddressed, but at least we can explore it in a sensitive manner if we have the eyes to see. So I think with this, I think we have a case presentation. Arya, can we go ahead with that?
Yes, sir. Dr. Shanmukha Priya is our case presenter. I will share the screen. Ma'am, please, can you please read out?
Yeah, sure, Arya. Thank you. So, good afternoon, everyone. So this is the case of Mrs. B, who is 47 years old. She was diagnosed with an invasive breast carcinoma on the right side, not otherwise specified, with the pleural metastasis. And she's still a managing partner in an overseas education consultancy, which was started by her and her cousin in 2018. Next slide, please. So this was the medical history. I have just put it as a timeline. So in June 2021, by self-examination, she found a lump in the right side of her breast. So when she went for her gynecological consultation, the gynecologist just told her the lump looks like a fibroid. And since she is 40 plus, it could be premenopausal. And she gave her some vitamin supplements and asked her to take for 3 months. In November 2021, the lump didn't go away. One of her friends suggested, why don't you go for something more of an investigation? Why are you just waiting it out? So she took a mammogram by her self-referral. And then the mammogram result came as it was a suspicious lesion with a 50% chance of being a breast carcinoma. So then in December 2021, she finally went for fine needle aspiration cytology, where the needle took a sample from her right breast and it was confirmed as a cancer, and followed by a biopsy, which confirms it as a grade 3 invasive carcinoma of the right breast with the staging of tumor size 4, and the same side lymph nodes were involved, and there was no metastasis at that time that is spread to the other organs. So from December 2021 till May 2022, she took 7 cycles of chemotherapy. In June 2022, she has removed her right breast. And from July to August 2022, she underwent radiotherapy. So after that, she was disease-free for a few months, from August till February. They repeated a PET scan in November. She was fine at that time. In February 2023, the PET-CT shows some deposits in the pleural cavity, the cavity which surrounds the lung. In the left side, the cancer was on the right side, so it was spread to the contralateral side, left side, and the pleural liquid fusion cytology shows metastatic deposits of the cancer cells. And after that, she was given 2 cycles of chemotherapy. The spread was stabilized, so she was started on tablet letrozole and palbociclib from then onwards, from February 2023. From February 2024, she took a PET-CT, and now the disease has shown an active metastasis. There was an increase in size of the pleural nodules. The stabilized disease now has become again active. And August 2024, recently, she took a pleural biopsy from that site, and again the same thing was confirmed. So it was estrogen and progesterone receptor positive and HER2 negative, and now she has been started on Faslodex injection, which is fulvestrant, and further germline testing for BRCA1 and 2 gene has been suggested. The specimen was given for that. The result is awaited. Next slide, please. So, to know about Mrs. V, she is a highly competent, intelligent, very vibrant person, very optimistic, a brave female, and she was diagnosed at the age of 45 with the breast cancer. And she has very bravely underwent all the treatment on her own. Actually, nobody came with her. She went for all the checkups on her own. And she has underwent all the options of curative treatment, chemotherapy, surgery, radiation. Now, unfortunately, the cancer has spread to the contralateral pleural tissues. And now she was told that by her primary physician, oncologist, that curative options has stopped. Now they are focusing on prolonging her life by stabilizing the spread. So let's see what happened with her pain history. So Mrs. V started to experience, so the first cycles from 2021 December till February 2024, pain was not a very major factor for Mrs. V. She had side effects in chemotherapy, pain after post-surgery, all those things. She braved it out very well. She was very optimistic, a very courageous woman. She was vibrant. Her friends who I spoke to, they all said that she was very optimistic. She never gave us the feeling that she is undergoing cancer treatment. So in by November 2022, she started to experience vague, nagging, continuous pain, which started in the left side under the breast area and radiated to the neck and the back. She was advised to go for PET-CT to rule out metastasis to the bone tissues. So it was ruled out. There was no bone pain. So from November 2022, she was, sorry, not 2022, excuse me, 2023. So she was shuttled between general physician, physiotherapist, ortho doctors. She was referred to everybody and no pain relief. So this was not as much causing her disturbance in sleep or anything, but this has become dominating her life. So in February 2024, the pain is getting worse. It started affecting her daily routine, impaired her quality of life. She was prescribed by her oncologist, medical oncologist at that time, take Dolo 650 3 times a day and Tramadol if needed. So this is what was happening till April 2024. The pain dominated her everything. Like that was the major thing. She couldn't sleep. She couldn't do anything. She started telling her friends that she is better off dying. So that much as the pain started. So she was given Ultraset, which is a combination of Tramadol with paracetamol 2 times a day. Again, no relief. June to August, the pain was so much that she hunches over and cries out, scares her younger nephews and nieces if they were around. That much was her pain. So she used to lock her inside the room when the pain gets worse so that nobody else sees the misery of going through that pain. So by August 3rd, 2024, one of her friends visited her and she took her to the doctor forcefully. Like, what is this? You're suffering from this much pain and the pain medication is not helping. So when she entered the hospital, she was hunching over with pain and breathlessness. On seeing her itself, the doctor said, really sorry, I didn't know you had this much pain. So this was something else. So they took an X-ray, found out that the pleural cavity has got fluid accumulation. More than 600 ml of fluid was tapped out. So after the tapping also, the pain didn't go away. Her breathlessness improved a little bit. So she was started on morphine, 10 milligram without any opioid trial. She was naive on opioid analgesic so far. But she was started directly on oral morphine, 10 milligram immediate release tablet by her oncologist. To be taken twice a day. And within 1 week, when she repeatedly complained, her pain didn't go off. She was increased to 30 milligram morning and night. And again, there was no relief. Next slide, please. So this is what we discussed now, the pain scale. So this patient was referred by a mutual friend to me on August 17th. So when I spoke to her, the first thing, she was like, she couldn't speak continuously. So when I spoke to her friend first, got her history. So a little background on the family is like she got married to her own uncle's son, consanguineous marriage. And they have one son. And they were living in Dubai for almost 20 years. and the husband got into some financial debts there, and he dragged her into that conflicts, and she was being harassed by the people who gave him money. So there, so she faced a lot of hardships there. So in 2017, she moves back to India with her son, who was at that time 8th standard, in the teenage. The son actually resented that, being coming back from Dubai, where he has all his friends and everything. But she had no other go because she was so humiliated there in front of other family and family friends. So she came back here in 2018. She starts her own business with her cousin, father's side relative. She lost her father when she was 16 years old. We'll see more about her family in the next slides. So she was here having her own business from 2018, and 2021 this happens. So she had to again establish contact with her husband after the diagnosis, but now it is like a very known basis, definitely no basis. That is how her relationship is with her husband. So I spoke to this friend who referred her to me through another friend. So when I spoke to her, that then we adjusted. After discussion with my colleagues, we adjusted because she's already in morphine now. So there's no point in again doing morphine trial. So we started her on oral morphine 30 milligram 6th hourly, because ideally it should be 4th hourly, but she was a little bit scared to do that. So we started at 6th hourly with paracetamol 650 also. 6th hourly. She showed a definite increase in relief of pain, but it was not optimal. So we again, after a week, because she had to take 2 or 3 extra doses of that 30 milligram morphine. So we adjusted the dose by August 25th. I adjusted back to 30 milligram every 4th hourly, and added gabapentin, which is a neuropathic pain drug, along with that with paracetamol. So after adjusting this pain medications and regulating her constipation, which is a definite consequence of taking opioids, with proper laxatives and continuous support by introducing a nearby palliative care center. So I referred, she's in another city, I'm in another city. So because it is through a mutual friend, I was talking to her over phone or video call the past 2 weeks. So I referred her to a nearby palliative care center after requesting her physician oncologist to provide her with a letter. So they provide her with proper morphine and other management. So now she has really got really better. She has started going out again with her friends, hosting relatives at home, and thinking of have been encouraging her to at least start work from home by referring some of my friends who are interested, whose sons and daughters are interested in going abroad for studies. So I have encouraged her to go back where our team has told us her to. Does this? I will get back to you, Dr. Payal, at the end of the presentation. So this is now after this pain medication, she is almost, I will not say 100% relief, but it was when I spoke to her first, it was like 7 to 8, she said. I will not say it might have been 10, doctor, but I don't know. Now I will say 7 to 8 maybe. So there is like Parag mentioned, yes, there is hesitance in even saying how much pain we are in. So she always says that 7 to 8. Now she says most of the time I stay in 2 to 4, that range, 3 to 4, that range. So she is very happy that she could sleep comfortably for 4 to 5 hours every day now in the night without getting disturbed. Next slide, please. So the diagnosis, the patient knows everything about her diagnosis. And the family also knows about the diagnosis. The immediate family knows about the diagnosis, her siblings and the husband, son, mother. The prognosis, the patient is fully aware, but a little bit of not complete information from her doctors. They have told that everything will get well. So, but she knows that once it has spread, there is no point of coming back to a normal thing. And the family knows that she has increase in pain, but they don't understand what is meant by a spread to the pleural tissues or the spread to other organs. palliative care, she has explored palliative care with her friend. So she is aware, but still in a bargaining stage, like she's not yet to fully accept that she's at a stage where she needs to go to palliative care, but she understands that her symptoms need to be managed and it is not a bad thing or so family also doesn't understand what is palliative care because she hasn't disclosed to them what she is doing. She has just told them that she is taking pain management from some other doctor. Next slide, please, Arya. Okay, sorry for such a bad drawing. 47-year-old Mrs. B is the patient diagnosed with the cancer. And her father passed away when she was 16 years old. She has got 4 siblings, one elder brother, and she's the second daughter, and a sister who lives in US, and 2 younger brothers. All her brothers lives in the same place where she is in Chennai, and they are all very close. They are very supportive to her. And the mother herself and her son lives in the same house now in Chennai, in a rental house. Husband, the relationship between her and her husband is somewhat apathetic and indifferent. And husband has got one sister, and his mother and father also lives in Chennai. But after some issues for the past 5 or 6 years, Mrs. B is not having a very good relationship with her in-laws. The father and the son are pretty close, but towards the mother, it was like a very normal relationship. And Mrs. B is very close to her mother, who is now her primary caregiver. Next slide, please. So the mother and Mrs. B receives a very extensive, strong support from the extended family, including her father's side cousin as well. Who's an advocate who always goes with Mrs. B for all the checkups or refer her to specialists or take her for any other investigations. And the friends of Mrs. B are very great support for her, the family friends, and also her employees and co-workers in her education consultancy. They're always there for her, praying for her. And Faith, we actually had a wavering experience. She was very religious, doing all the rituals before the diagnosis. And even after the diagnosis, she was very hopeful and all those things. But when it came back, when she was told that there is a spread to other organ, there was so much of anger, frustration, all those things. And in healthcare also, she has got very good connections with the healthcare community. Through family and other things. So she has got a very good support. Her primary physician, the oncologist, is always willing to listen to her concerns and refer her as needed. But the immediate family, spouse and son, it's a very weak support system, which bothers her. Next slide, please. So, as already mentioned, husband works in Dubai. He still has his debts and other issues. So they have separated temporarily in 2017, and she has come back to India. She has started her own consultancy in 2018. Currently, she's not able to go to work actively. Now the spouse, they have come to some kind of agreement where he sends some money to her, and she manages within that money and whatever her savings from her business earlier. And the spouse has debts, but she was released of any liability for those debts. And health insurance is available from both husband's work as well as her own insurance, private insurance is also available for her. Next slide, please. So psychological overview. Sorry, I couldn't take this in depth. So when in August 17th, when she was with the distress thermometer, her distress level was almost at 8. And the main reason is the physical pain. She was like, I can manage anything. I have overcome so much difficulties, doctor. But this pain is like taking away the control I have of my life. I don't have control over anything. My dignity is lost, and I get advices from everybody. Everybody say I have to be brave and I should change my mindset. If I get used to morphine, then that's all. I will become an addict. And nobody is actually concerned about the pain. They don't understand that this disease has spread. And they think that just with my positive mindset and being optimistic and being faithful to the God and all those things, I can overcome this disease and this pain. but I don't understand how just a positive mindset will let me release me from this kind of pain. So that is her main concern. Otherwise, there is no intimacy with the husband for a long time now. She feels no attachment whatsoever or no extreme distress towards her relationship with her husband. With the son, she has slowly started to tell him what she is going through after I encouraged her to talk to him. So that is what her psychological thing. Can we go to the next slide? So with total pain, the physical pain, as I have already mentioned, it is her main things that bothers us is the pain, constipation, loss of sleep, and tiredness. And psychological is lack of support from spouse and son, and denial from well-meaning friends and family members that it's getting worse. And socioeconomic, now she feels like she was earning on her own. Now she has to depend on her husband. So spiritually, it is wavering faith. She is questioning the purpose of her suffering. She has already gone through so much of suffering in financial and other things. So why should she suffer more? Next slide, please. Can you excuse me just a moment? Just a moment.
So meanwhile, this is just the kind of case scenario which is showing that the impact of pain is so much in all these dimensions. I'm so glad that you have brought out and gone into so much details and the equations between the family members and about how she has been an independent woman, but still how there was certain elements of dependency, and how she has been able to manage it, come out of it, and stand her ground for doing what she needs to do. So this is a excellent case presentation, I must say. Also, no, when this topic was there, probably these elements you could have given as a background to the case also, and then gone into the medical aspects. For this particular topic, that would have also been okay. But wonderful to know that already you have started going into so much depth in knowing things about a person where everything we may not be able to do something about, but at least you explored. Wonderful.
So this is what I want to discuss with our cohort, like the awareness about pain management, not even the health fraternity. It was a personal experience also for me, and I am ashamed to say how many times I would have prescribed saying SOS for the dental extraction, or even given advice to the patients when they say like, no doctor, the pain is so. So I was not aware of the analgesic ladder, which should have been the main line of treatment, especially in our field, where the anxiety of sitting in the dental chair itself causes pain for the patient. So the pain management awareness is very, very low among the health fraternity. Is a truth. It's a fact. And also like how we explore the societal, cultural expectation of endurance of pain. That is celebrated, like Mr. Parag said, that is very true. So that is where this coming from. You have to change your mindset. You have to be bold. You have got cancer. So what actually really frustrated me is when she told that in April 2024, she's going with so much pain to her medical oncologist. Nothing was told, actually. She was not even told there is an option of pain management. And she lives in Chennai, where there are a few palliative care centers, including the Cancer Institute, dedicated for cancer pain management. She was not given any of those options. It was not even thought about, and the misdiagnosis in the first point. So there are so many pitfalls that has happened, but it was only through people exploring on their own. Even now, all the experience what I had in few other palliative care centers, it's either by word of mouth by other patients, or when they explore on their own in social media, they come to know about pain management. It was never referred to them by the healthcare practitioners. So, and they don't want to, even this, I am very happy and grateful that he at least agreed to give a referral letter to that palliative care center because she would get a morphine from them. But otherwise, they totally refuse to even collaborate or cooperate with the palliative care provider, service provider. That has been the experience so far. And the psychosocial support system, they have everybody is very supportive, but when it comes to understanding the prognosis, including the support system into the system by declaring to them what it means for the patient and for the family is still lacking. And caregiver support. The mother is 67 years old. She has her own issues of back pain, other things, and she is not completely aware of, and she doesn't have any financial background support system. She lives with her daughter now. Something happens to her before her, then she will be shuttled between other sons and daughters. And even now, there is a little bit of tiff that the mother has to stay with her all the time because of her illness. When the other brothers are having smaller children and they both are working, so the mother has to be with her all the time. So those are the things.
Thank you so much, ma'am, for the presentation. I won't hold anyone longer for too long because we have overshot time. But this was the pain management which was done in this case seemed appropriate. But definitely the awareness bit of it, whether it is any of these dimensions, I just want to give a take-home message to everyone is that this movement begins with us. Each one of you have that capacity as well as the responsibility to talk to at least your own colleagues or to your near and dear ones and to just make them aware that such a thing is there. This is how that snowballing happens. Snowballing phenomenon, the ball, when it starts rolling from the top, it's a small ball. But when it comes downhill, it becomes a bigger ball. Just like that, each one of us should take up that responsibility to inform people near and dear to us and to our colleagues and friends that there is something called as palliative care. We may not be able to do anything yet. We may not have the systems for it yet. But in the social sphere, there are so many things which needs that community to come together, for people to come together and to contribute towards a cause. And all these causes are interlinked. It is not just palliative care, health-related expenditure or something. In the social world, there is so many elements which needs addressing, and palliative care is also a beneficiary of that. Like if we have a good NGO or a good set of people, a group of volunteers or institutions who are working towards some cause, I'm sure that there are cases in palliative care also which will benefit from those. Right? So this is something which we need to keep in mind, that pain and its impact much beyond the four walls of an OP or an OT. And the solutions also lies outside those four walls only. And it begins with all of us. So I think we'll have more sessions and to interact. But for today, we have already overshot time. My apologies also for the initial technical issues which happened. But if any of you have any questions, please feel free to send it to Arya. She will get back to me, and if I'll get back to you with the answers and the responses. So with that, thank you so much, one and all, for patient listening. Thank you so much, ma'am, for your wonderful case presentation. We may be trained in doing something, but in palliative care, we have to start learning to look at everything, all dimensions. Okay. So with that, I'll hand over to you, Arya, for the evening. Thank you.
I thank you, sir, for the wonderful session. It was such a good session, really. I thank Dr. Shanmugapriya also because it was such a brilliant case presentation. And I thank each and every participants for the interactive participation. I thank everyone. We will meet on Thursday with the scheduled topic. Thank you.
Thank you.